Good afternoon and welcome back. I'm Lauren Harden, one of the PTAC members, and we're excited to offer this afternoon two very interesting sessions focused on lessons learned from state value-based care models that have implemented multi-payer alignment. In the first session, we will hear about the Maryland total cost of care model and the Vermont all-payer ACO model. In the second session, we will hear about the Pennsylvania Rural Health Model and the Arkansas Healthcare Payment Improvement Initiative. At this time, I'm happy to welcome for our next session 4 remarkable experts to discuss the multi-payer models in Maryland and Vermont. You'll find their full biographies and slides posted on the ASPE PTAC website and the public meeting registration site. At this time, I ask our session participants to go ahead and turn on your video if you haven't done so already. All 4 experts will present, and then our committee members will have plenty of time to ask questions. First, we're very excited to welcome back Ms. Katie Wunderlich, who is the principal of KKW Consulting. Welcome, Katie. Please go ahead.
Thank you, Lauren, and welcome and nice to be with all of the PTAC members virtually. My name is Katie Wunderlich, and I'm going to talk a little bit about the Maryland total cost of care model from the state's perspective. So there'll be other panelists talking more about the provider or other perspective, but really want to give you a little bit more in-depth experience and or feedback from the total cost of care model from a state perspective. So the next slide just talks about just basic learning objectives. I want to try to identify some of the strategies that we used during the model that facilitated specifically multi-payer alignment and contributed to the success of the model, how those strategies were used to enhance certain parts of the model and to drive success. And third, finally, of course, understanding how these lessons or strategies could be used to inform future developments of value-based care models that align multi-payers in CMS models. So the next slide, I'm not going to go through Maryland's total cost of care model because I know you all have heard lots about it. There have been many evaluations, but just a little bit as a slight background. We have operated under a CMMI model since the inception of the Innovation Center in 2014. So we had the all-payer model from 2014 to 2018, and then the total cost of care model from 2019 to 2025. Really, during that time, the state demonstrated success in reducing total cost of care, reducing unnecessary utilizations, adding enhanced primary care, and developing coordinated statewide population health interventions to drive success. The state largely met or exceeded all contractual goals, and that eventually led to the evolution under AHEAD, which is where Maryland sits now, under the AHEAD model within CMMI. Now, the contract for both the total cost of care model and the all-payer model, they included Medicare-focused metrics. However, there was intentional alignment with Medicaid and commercial payers on both cost and quality metrics that was really crucial for maximum impact and for broadest reach of the model. So for the rest of this presentation, I want to talk about 4 specific strategies that I think were really important from the state's perspective to drive success under the value-based care model, which was Maryland's total cost of care model, and specifically why it's important from a multi-payer perspective. So those 4 strategies here: utilizing existing infrastructure to build on successful care delivery models, creating a governance structure that's inclusive of all healthcare entities, generating buy-in and stakeholder engagement in both implementation of the model and then also methodology development as the model evolves. And then finally, identifying shared objectives for statewide priority to leverage resources and improve chances for long-term sustainability. So those are the 4 kind of lessons that I'm going to go through. On the next slide, we'll start with the first one, really why it's important and what are some of the examples of how it played out in Maryland. So the first one, utilizing existing infrastructure. This is so important to understand from a state's perspective. What does the history and context of that state or that region look like? Who are the existing players? What are the existing payment and care delivery chassis? It's really important to understand where states and regions are starting with, so that you can build onto successful and already existing infrastructure for care delivery, for different alternative payment models, for care coordination. This really increases the chance of sustainability when it's built on an existing platform. So that would be the very first thing to really drive home, to increase the chances of success. And how that played out in Maryland, we have a history of an all-payer system. As I mentioned, we had been under CMMI models from 2014, but even previous to that, we had a history of all-payer rate setting systems. So we had a history of engaging and aligning payers within the state of Maryland, under regulatory structures and also under healthcare delivery system. The other example is our state designated health information exchange. The acronym is CRISP in Maryland, but it enabled data to be shared across providers and settings. And this was really important for care coordination and risk stratification as the model developed. It was a really important piece of infrastructure that we had as a state, that we continued to invest in, that was really important, an important piece of success. The next slide goes to lesson number 2, which is an inclusive governance structure. And governance structures are required and encouraged by many CMMI models. They are both at the beginning when you are setting up a model, but then work group governance structures to monitor the model as it goes forward. It's so important to have, for there to be those governance structures to be inclusive of multi-sector representation, multi-payers, providers, health systems, state agencies. Those governance structures and work groups, moving forward, they really benefit greatly when there is engagement and representation from the different healthcare sectors. And this really helps to create methodology that's transparent, that can evolve over time as necessary. In Maryland, there were a number of examples of this, both at a high level, a governor's stakeholder group that was really a very high level, broad stakeholder group that was meant to kind of be the vision for the model in Maryland. But then there were also ongoing work groups where that were attended and participated by payers in Maryland, providers, community organizations, et cetera, that helped to look at payment models, so developing innovative payment and delivery models that bridged those different specialties between primary care, specialty care, inpatient, post-acute, long-term care. Having representation on these work groups helps to understand, what does it look like on the ground? What do we need to change? What obstacles are there? Where can we address issues of operational feasibility as you roll out models? So really having an inclusive structure, an inclusive governance structure that hears and has representation from many groups. The next slide is the third lesson that I wanted to kind of talk about, which is generating buy-in through strategic engagement. So of course there is buy-in through ongoing governance, but really as states are looking to add tools, or as models are looking to add tools, it's really important to go right to the provider organizations that are going to be delivering the care, to understand, and the payers who will be supporting those provider organizations, to understand how tools can be added. So why this is important, of course, strengthening that provider participation and model stability by getting feedback, addressing fragmentation of care, which we know happens regularly in healthcare, but engaging payers and providers in that model development helps to address that fragmentation, increasing the chance of long-term viability. Again, methodology development, understanding that methodology, and then, of course, creating consistent quality and financial targets for providers to work towards. So Maryland did this in two strategic tools that it added to its value-based care model in the total cost of care model. One was Maryland's primary care program, which we know is a really important element in value-based care to put prevention and investment upstream to improve health. As Maryland was looking to develop that primary care program, it reached out to Care First, which is one of the major commercial payers in Maryland, to help identify and align the Medicare primary care program with the Care First PCMH. So to help address provider administrative burden for primary care providers, really was important to make sure there was alignment, strategic alignment for the primary care program. The second example in Maryland was a bundled payment program. They called it EQUIP, Episode Quality Improvement Program, and it really is a bundled payment program for specialists in Maryland. And as the state was putting it together, it's a Medicare program, but they used episode groupers that the commercial payers used to foster that alignment. So not exactly, a matched program, but the underlying episode groupers the state really wanted to use something that could be adapted by the commercial payers when they were ready. And so really enabling that connection during strategic times, in strategic instances when the model was being developed and when these tools, primary care tool and the specialty bundle payment tool was being developed. On the next slide is the fourth lesson I wanted to talk about, which is identifying statewide or regional priorities that include shared objectives. And this can really spur engagement and really make limited resources go so much farther when you identify what priorities and programs payers in your state or region are focused on. Then you don't duplicate resources. You can leverage those existing underlying programs, increasing feasibility and long-term success. Really important because we know that states have limited resources, payers have limited resources. So to the extent that we can identify where there are shared and overlapped goals, we can leverage that instead of duplicating. And in Maryland, I want to talk about two examples of how this played out in Maryland. One was the statewide integrated health improvement strategy was kind of the quality and population health addendum to the contract, and it identified population health goals and care coordination goals. And one of the population health priorities that both the state and Care First, our commercial payer, had was around diabetes management. It was a driver, diabetes was a driver of poor quality, poor outcomes, and increased cost. And we really saw that as an area where we could work together, public and private partnerships working together to address a major chronic condition in Maryland that would benefit both the residents in Maryland and also the payers, Medicare, Medicaid, and commercials. And then the other example in Maryland were our regional partnerships and care transformation initiatives. And this encourages hospitals, provider groups, and payers in certain regions to work together on shared goals. There was some state seed funding, but still it encouraged and enabled that collaborative work for a specific population in a geographic area. On the next slide, so, those were the four that I thought were really important to point out to really increase and improve the chances of success in multi-payer models, driving value-based care and total cost of care. And again, just to kind of reiterate some of the themes that I've mentioned, why does this matter for multi-payers? One, because we want to enable providers to actually be able to implement models. And to the extent that we can reduce administrative burdens, we can create consistent incentives, we can strengthen that provider participation by aligning financial and quality incentives across payers. It really helps the provider community be able to participate more fully. And of course, enabling that broad population impact and long-term sustainability for value-based care. I have just one more quick little slide. This is really towards what, how can we use some of Maryland's takeaways as we look at what does the future development of value-based care models look like, specifically trying to facilitate multi-payer alignment. Really, that is the key word is alignment, having clear shared goals, standardized quality and performance metrics, transparent data, transparent quality and financial methodologies and the development of those methodologies, strong state and regional conveners to make sure we know what's going on the ground. How can we relay that back to payers and providers, and engaging them early and often. So a few of my takeaways that could hopefully inform and direct some future model developments for value-based care. That concludes my slides, and I'm looking forward to hearing the rest of the panel.
Thank you so much, Katie. Very interesting. We're saving all questions from the committee until the end of all presentations. Next, I'd like to welcome Dr. Joseph DeMattos, who is the Senior Vice President of Public Affairs at Marquee Health Consulting Services. Joseph, please go ahead.
Thank you for the warm welcome. And I wish it were doctor, but it is not doctor. Thank you all so very much for being here. I'm looking forward to hearing more of my colleague presenters as well. Katie, my friend and colleague, did an outstanding job teeing up our total cost of care model and its evolution and how we can continue to inform more efficient, better care in the future. I think the undercurrent word that I heard in Katie's presentation was collaboration. Collaboration at the start, in the middle, at the end, as we adjust. And honestly, I think collaboration in Maryland under Katie's leadership and others really was a differentiator. But going again in next slides, I'm presenting here based on my experience as the president and CEO of the Health Facilities of Association of Maryland, which I had the privilege of leading from 2009 to 2025. It was at the time the largest, oldest provider association representing skilled nursing and rehabilitation centers, senior living in Maryland. We had 226 SNFs and a handful of CCRCs and a bunch of assisted livings. More presently, I work for Marquee's Health Consulting Services. We provide administrative and consultative support for 118 facilities in 8 states. Here in Maryland, our campuses provide more than 300,000 days of post-acute and long-term care in Maryland or to Marylanders in need. Next slide, please. And so this I've already covered, but I think the workforce is really, really, really important, that the post-acute workforce in many of the communities in which these 226 SNFs operate, they're the largest employer. And most of those communities, that care provided for, whether it's post-acute or long-term care to the patient or the resident, is closer to the home and to the family members of those patients and those residents. So with a combined workforce of both direct and indirect of about 72,000 workers here in Maryland. Next slide, please. Now, a key point, and something that is a historic strength in Maryland, is that we don't have LTACs in Maryland. And so Maryland Skilled Nursing and Rehab Centers, SNFs, have been providing fairly high-level post-acute care for close to 40 years in Maryland. We led the nation in post-acute ventilator care in the country. And there were times when we had pediatric long-term care units that were not present in the rest of the country. And that's really important to the throughput that's relied upon by Maryland hospital providers under the total cost of care contract. Next slide. So this begins a series of slides about chronic care, and I tremendously admire the work of the physicians on this call and Dr. Howard Half, who was instrumental in the primary care model under the total cost of care contract and how it was designed and implemented. Job number one of these physician-led models is the management, the cost-effective, but more importantly, the clinically efficient methods of reducing, and in the case of the total cost of care model, the number of Marylanders that convert to pre-diabetes to full-blown diabetes. And the good news is that the work that we did on the total cost of care contract made a difference on that front. The bad news is that there's still so much work to be done in Maryland and across the nation on bending the clinical incidence and the costs of managing chronic illness in our country. We haven't fixed that yet, and we're not going to fix it on this call, but maybe we can talk about some ways together that we can work towards fixing it. Next slide. So this slide just gets into the specific fact that Maryland is aging a little faster than the rest of the country. And, we on this call and the leaders at PTAC, we all decided that this was going to be a virtual meeting, brilliantly so, given the snowstorm. But let me say that just about 3 miles from where I am presenting on for this conference, the life expectancy goes down by more than a decade. 3 miles in Maryland, where we have some of the greatest healthcare in the world, where we're one of the wealthiest communities in the country, where we have more PhDs in Bethesda than in any other zip code in the country. I go 3 miles that way, cross over a street, and the life expectancy due to chronic illness goes down by a decade. Next slide, please. So again, this talks about the fact that we're aging a little faster than the rest of the country. And we are facing both, in economic communities across the spectrum, prediabetes is a major issue in Maryland. It is not just a poor person issue or a socioeconomically driven issue. It's worse in underserved communities, dramatically worse. It's something that's touched my family directly in that way, but it's prevalent across the board here in Maryland, rural, city, socioeconomically. Next slide. So I don't do any presentation without reminding people, you all know this on this call, on this Zoom, but the workforce crisis from physician to aide to non-care workers was going to be a crisis pre-pandemic. We knew of this crisis. We've been focusing on it as a community. The pandemic shone a bright light on it, but we haven't fixed that yet either. We have not dramatically increased the number of nurse educators in our country. And as a result, we haven't dramatically increased the number of nurses that we need. That first statistic about Maryland is from the Maryland Hospital Association, and the second one is a national statistic about nurses' aides. And of course, I could have just as easily put up one with regard to physicians, right, where medical schools get tens of thousands of applicants for hundreds of slots. Next slide, please. As a recovering politician, this slide always bothers me the most. We have known that we've needed to reform financially Medicare in this country, Social Security a little less, but Medicare much, much more. We have a national post-acute payment system in Medicare. We still don't have a nationally responsible system of providing for long-term care. It's largely a Medicaid system relying on our friends, neighbors, and family members to plan and or go broke in order to have their long-term care paid for in a center-based environment, in a country of more than 300 million people. We have only 15,000 nursing homes and just a little over 1 million beds. So this is just a tiny part of the continuum of care. Next slide, please. So getting to that point that Katie was making, and I want to reinforce, and that is that whatever success we have today and going forward, or success that we had in the past in fighting the pandemic, comes from collaboration. And what people, providers, and payers all seek, in fact, families in our care seek as well, is they seek predictability. They want to know when their family member is going to be better and how much better and where and when and what's going to be their new normal. And understanding predictability happens at that intersection of having shared goals and buy-in that are both driven by the financial necessities and the clinical necessities of the situation with regard to bending the curve on chronic care in our country. So it begins with shared goals and predictability. Next slide, please. Now, I think, and also this first point is one that I always make when I speak publicly post-pandemic. I think it was a huge advantage that Katie and I had each other's cell phone numbers going into the pandemic, and that I had the cell numbers of the hospital CEOs and of the long-term care providers, and then eventually the National Guard commanders. We all knew each other because of the work we did on the total cost of care and evolving it over that time period. We all knew one another. We all worked together. We all had tough conversations together. That collaboration, I'm convinced, saved lives during the pandemic, and it elevates the difficulty, the kind of difficult conversations that providers can have, both clinical providers and physical spaces, hospitals, nursing homes, assisted living, home health care. Having those relationships and having a history of working collaboratively kind of gave us permission to have what the authors of the book Critical Conversation speak of, tough conversations where we could get to some meaningful agreement. Next slide, please. So, success going forward means that we need to work to establish clear shared parameters for quality, cost, utilization, and outcomes across all payers. Now, we did a really good job in that in Maryland, but where we can advance that work is moving from collaborative sense to an ownership sense. Providers are willing to own upside and downside financial risk, but they have to know what the measurements are and know what the rewards are, and be in a position on the decision-making side to decide how they can affect that with regard to dollars or care going forward. And it's something that I think Katie and I eventually started laughing about, but moving from a transactional vendor relationship to a long-term strategic continuum of care, partnership, ownership, so we so often look at the cross sort of professional on care being the physician and the nurse caring team, and the platforms, let's say, being hospitals, nursing homes, assisted living, home health, And those levels of care, we look at them as upstream and downstream and kind of vendor relationships. And instead of looking at them as upstream and downstream, looking at them as one stream, where we're not actually vendors, but we are full ownership partners. That's sort of what the future looks like. And that's why I'm really excited to learn more about the Vermont ACO model. And that's why I'm excited to continue my work with Katie on the AHEAD model, because I'm convinced that that's part of the success of those models. Next slide, please. So again, one of the things that we have going for us in our various sectors right now, and I'm really proud of in my current position with Marquis Consulting Services, is the disease management programs that various operators across the country, including Marquis, have put in place. So physician-led chronic disease management programs that are managed across the continuum of care with our acute care partners on congestive heart failure and pulmonary disease and diabetes. And I'm just excited that on the work that we do. And I'm excited that that work has been augmented by those providers, but only about 20 of them in the country that have instituted iSNPs. Again, I'm a huge fan of iSNPs, but one of the barriers is the state-by-state regulation on the insurance model and the cost of putting capital up front, which excites me more about sort of the ACO model going forward, right? Now, right now, I'm also excited that in our sector, we're using AI pretty dramatically to determine risk and clinical match with regard to patient selection. But that's only one use of AI. And I'm excited about expanding the use of AI across the entire continuum of care, but most specifically in the post-acute long-term care environment. Next slide, please. So again, this is, I think, getting down to the near second to the last slide. We have to serve as true partners at the intersection of quality and cost. It can't be quality, period. It can't be cost, period. It has to be quality and cost. We have to commit in advance to shared opportunities and shared risks. And getting back, we have to collaborate to define what success looks like in advance with regard to metrics, financial accountability, and reinvestment strategies. Next slide. And then this is just a synopsis of my methodology and sources for the slide. So with that, I look forward to hearing my fellow presenters and to the Q&A period.
Thank you so much, Joseph. Again, really rich content. Looking forward to asking questions after each of the presentations are over. Next, we're very pleased to welcome Ms. Ena Backus, who is a senior consultant at Friedman Healthcare. Ena, welcome. Please go ahead.
Thank you so much. My name is Ena Backus. I am a senior consultant with Friedman Healthcare. Friedman is a focused independent consulting firm dedicated to improving healthcare access, affordability, equity, and quality, and in particular, doing so by empowering our clients with actionable data. We can move to the next slide. While I am a senior consultant with Friedman Healthcare now, I was previously the director of healthcare reform in the state of Vermont. And prior to taking on that role, I was the chief of health policy at the Green Mountain Care Board in Vermont and played a role in negotiating and implementing the state's all-payer ACO model agreement with CMMI. We can go to the next slide. For my conversation with everyone today, I'm going to talk first about the All-Payer Accountable Care Organization Model Agreement and give you a high-level overview of its multi-payer parameters. Then I'll take a step back and talk about the State Innovation Model Grant and how these funds, which were awarded to Vermont in 2013, helped to lay the groundwork for the all-payer model. I'll touch on a lot of the themes that Katie and Joseph covered in their presentations relative to governance, buy-in through strategic engagement, collaboration, and the state's role in supporting multi-payer alignment. And then I'll talk about implementation of the ACO model agreement and some of the challenges and opportunities in that work. And also circle back to some of the structures that the SIM grant and the state initially supported and may have promoted continuous improvement and alignment across payers and state partners had these structures been utilized more consistently through the performance period. So we can go to the next slide now. And I'll provide an overview of the all-payer ACO model agreement. Vermont certainly followed in the footsteps of Maryland in working with CMMI to develop a state-specific alternative payment arrangement. We worked collaboratively with CMMI over a number of years, informed by the work that was going on in the state of Vermont with the SIM grant, to put together a statewide transition to value-based care that was really based in these pillars. Moving away from fee-for-service reimbursement was a key component of the agreement. Aligning payer programs for ACOs in the value-based model was another critical component of the all-payer agreement, as well as scale targets. And scale targets were both necessary for ensuring that enough people were attributed to the model for there to be benefits for providers in terms of alleviating administrative burden, having a common incentives across payer groups. But the scale targets were also very ambitious and were a component of the model agreement that was difficult to achieve given the state's regulatory purview over the self-insured payers in the state in particular. The model agreement also included all payer and Medicare total cost of care targets, and these were consistent with the state's overall total cost of care targets. There was a per capita expenditure growth target of 3.5% over the model agreement period, with a ceiling of 4.3%. And then there was a specific Medicare growth target included in the agreement as well, so that the state's Medicare spending would stay slightly below the projected national average over the 5 years of the agreement. The agreement also included ambitious population health outcomes targets, which included increasing access to primary care, decreasing deaths due to drug overdose and suicide, and lowering the prevalence and morbidity of chronic disease, specifically COPD, diabetes, and hypertension. We can move now to the next slide. And as I said, the State Innovation Model Grant was a really key component for providing the groundwork for the state to enter into the all-payer model agreement and to develop its aligned priorities and requirements for participating in such an ambitious model. The SIM grant for Vermont provided $45 million for the state, and these funds were utilized to create a pretty comprehensive system of work groups and initiatives that were really testing value-based payment arrangements and also providing a convening structure for stakeholders across the continuum. These stakeholders, including payers, healthcare providers, community providers, state officials were overseeing the convening, and these were critical pieces into developing aligned structures and these would ultimately inform the all-payer agreement. So these included work groups that were focused on payment reform and incentive structures, and these work groups really delved into ACO infrastructure development, shared savings programs alignment, value-based payment models, and the eventual evolution into the ACO model. The SIM structure also supported care integration and care coordination, and this included practice transformation support, care coordination, capacity building, regional infrastructure strengthening, linkages with the existing blueprint for health in Vermont, the patient-centered medical home. And the SIM infrastructure allowed for clinical and economic data, health data infrastructure expansion, supporting the adoption of electronic health records for those practices that have not adopted them previously, interfacing, building analytics capacity, and building standards for data standardization efforts. And just some examples of what was accomplished through these work groups. And there were, like I said, multiple simultaneous work groups that were being supported with state officials, contractors, meeting on a regular basis, working collaboratively and in partnership. And they were focused on governance requirements for ACOs, payment methodology and calculation of shared savings and risk payment for ACOs, patient attribution for ACOs, and financial stability provisions for ACOs, as well as significant work on quality and performance measures to align across payers participating in ACOs. The standards were developed initially for the shared savings program, which was also implemented in Vermont with alignment across Medicaid, commercial, and Medicare. And this really was the springboard for aligned standards for the ACO model. We can move now to the next slide. So I just covered some of the standards, but here we can see in more detail, these standards were developed. They included governance, payment methodology, payment attribution, financial provisions, and quality and performance metrics. What I think is really important about this work was that the work was convened, supervised, encouraged by the state. There were funds available for contracted support through the State Innovation Model Grant, and everyone was at the table to align in these standards and requirements. That means that commercial payers were at the table, providers were at the table, as well as the state Medicaid program. And this is really what fostered the state's ability to then pursue the all-payer accountable care organization model agreement. We can go now to the next slide. The regular work group participation funded through the SIM program created shared understanding, collaboration, and an opportunity for payers and providers working together in the state to move away from fee-for-service, to workshop one another's ideas, and to troubleshoot and engage in continuous improvement. These structures were not in place for the entirety of the agreement, and those structures may have enabled more coordination and more ability for addressing some of the challenges that came up had they been maintained throughout. Some of the challenges, and I know that my colleagues at OneCare Vermont will likely talk about these challenges as well, but there were some critical challenges with the implementation of the model. One challenge was fidelity to fee-for-service. The model was really rooted in moving away from fee-for-service. When we were doing the work to negotiate the agreement, We understood that Medicare would be offering the Medicare Next Generation ACO program, and that program would move aggressively away from fee-for-service. However, when the payment methodology was finally specified, there was a full reconciliation still for Medicare to fee-for-service. And that was more rigid than what we had expected and was certainly a challenge for aligning across payers, whereas the state and the Medicaid program in the state had moved fully to an unreconciled prospective prospective payment. Another component that posed a challenge for implementation of the agreement was stakeholder participation and the scale targets. And these scale targets, as I indicated, were very ambitious, but there was also, I think, in part due to the way that the model was being implemented, perhaps there was not enough stakeholder engagement to support the scale targets throughout. Keeping the payers at the table was a really important component. Bringing the payers to the table is also a really important component to implementing the Vermont all-payer ACO model agreement. And the structures were not maintained throughout the entire performance period to keep everyone at the table. Scope creep was another challenge for model implementation, meaning that the all-payer accountable care organization model agreement, which was being implemented with one ACO participating statewide in the state, was really looked at as a solution to all of the issues for the healthcare system at once. And that was a difficult piece for the ACO to negotiate in terms of being able to maintain focus on improving value, delivering higher quality care. And also another challenge was the patient perception. This was a very high profile implementation in the state of Vermont. Many people were aware that healthcare reform was happening through the all-payer ACO model agreement, but were unable to understand how those changes in care delivery were impacting them. And so those were challenges for implementation. There were many opportunities as well, and there were many good outcomes to the implementation of this model. I think that my colleagues at OneCare will talk more in detail about the savings that were generated for the Medicare program, in particular, the quality improvement gains that happened through the implementation of this model. And I also think that this scale of participation does speak to the state's support for collaboration over the period of time leading up to the agreement and then throughout as well. But 8 hospitals out of 14 participated across all payer programs in the agreement. The primary care model that OneCare put into place was extraordinarily successful. It aligned multi-payer payment reform and provided predictability and flexibility for primary care providers where there had not been previously. The data and analytics, in part, accelerated through the SIM process, and the work groups focused on data analytics, and also through the ACO's implementation, really provided for improved data and analyses for transformation. And there was better access through the implementation of the agreement to more appropriate levels of care, particularly facilitated through the waivers that were available to the ACO. And those waivers similarly allowed for OneCare to leverage its very large statewide network across the continuum of providers. And so again, I'll close my presentation by emphasizing that in order for there to be success with all payer or multi-payer reform, there really does need to be, I think, a very clear focus on multi-payer alignment, the carve out of time and focus on work group activities, state supervision to bring people together and keep people at the table in terms of staying aligned over time. Thank you. I look forward to the discussion.
Thank you so much, Ena. Again, really valuable content. We'll be diving into questions after this next session, and I'm very honored to welcome OneCare Vermont's Chief Medical Officer, Dr. Carrie Weigand, and Chief Executive Officer and Chief Financial Officer, Mr. Tom Borys. Welcome, Carrie and Tom. Please go ahead.
Thank you very much. We appreciate this opportunity. Like Lauren said, I'm Dr. Carrie Weigand. I'm a family physician. I've been seeing patients for more than 25 years in the same practice in Vermont and still love it. And I'm also the Chief Medical Officer at OneCare Vermont. And I asked Tom to join us today too. I'm so glad he has. He's going to go first. More about the operations of the ACO, and I will go after him and share more about the clinical aspects of the ACO that we've been working on in the past few years. I want to say thank you to Ena. I think she did a great job of setting the stage for what we want to talk about. We were told we had 10 minutes, so we may not be as detailed as you would like. I think we will be able to answer questions in the question session later, and always happy to come back if you have more questions. I think you are going to hear some repeat themes that were shared by our Maryland friends, and I'll turn it over to you, Tom, to go next.
All right, great. Hi, everybody. Nice to speak with you today. So a little bit of context for OneCare Vermont. OneCare is an administrative entity that manages multiple accountable care organization or ACO contracts on behalf of provider organizations. We've been referred to as the ACO in Vermont for years. I actually don't think we're the ACO. The provider groups are really part of the ACO, but our job is to run and manage the complexity within ACO contracting. Organization was formed in 2012, and we simultaneously managed Medicare, Medicaid, and commercial arrangements throughout our history. And our market was really the state of Vermont, a little bit of New Hampshire as well. So we had a broad reach in the region. In 2018, the Vermont All-Payer ACO Model Initiative began. It's a complex arrangement, but when you really boil it down, to me, it's a test of scale. And ask the question, if ACO participation is spread across a region, will cost growth slow and quality improve? So that was kind of the hypothesis of the program itself. As such, we positioned OneCare as a come one, come all ACO in spirit of the APM all-payer model's goals. Ena spoke of the scale targets, which were targets for a number of attributed lives. So in spirit of that statewide goal, we really invited anybody to come in as long as they're willing to contribute and put in the effort. What's a little bit unique is that we're technically not a signatory or a party to the Vermont all-payer model agreement or contract, but our work slotted in underneath that, and happy to talk about those dynamics a little bit more. The all-payer model in Vermont ran through the end of 2025. There are, I think, thoughts of transitioning to the AHEAD model, but that didn't happen seamlessly in the state of Vermont. And OneCare is actually in the process of winding down business operations now. So we're just kind of concluding our 25 business, and then we'll turn off the lights sometime later this summer. Next slide. Multi-payer alignment, is it worth the effort? Yes, with an exclamation point. I think it's a great goal to pursue. The benefit of aligned ACO or really other value-based care arrangements is that it gives providers a more holistic operating paradigm. That's really important. And when these initiatives are aligned across payers, the care delivery approaches will be more patient-centered rather than insurance-centered. And if a provider has to look up a patient's insurance to know what to do or what to prioritize, I think we missed the mark. And really just to kind of move those dynamics of who's insuring the patient to the back and moving the patient forward is a good goal to aspire to achieve. Once you get some multi-payer alignment, other opportunities start to show up. There's new opportunities for collaboration and relationship building between separate provider organizations, especially if you're under one ACO umbrella. There are opportunities for pilots and innovations that start to make more sense when you're on the same programs and have alignment across the different payers. Opportunities for payment reforms. We designed and operated a program for primary care that blended their Medicare, Medicaid, and commercial revenue into one monthly fixed payment. And that was a really successful initiative for us and simplified revenue generation and management for primary care practices. And then you can also redirect funding within the system and move it to high value areas like primary care or skilled nursing facilities or home health care to help build the foundation of a strong and high functioning healthcare system. Next slide, please. I think this visual is really important. Structure matters a lot here. And I think a centralized entity is recommended, if not essential, to do this. One of the barriers to multi-payer alignment is contracting. The visual on the left shows the contracting model without a central entity where every payer needs to independently contract with every provider organization, and it becomes this super complicated matrix of contracts that is burdensome everywhere for the provider organizations and upstream for the payers as well. So when OneCare installed itself in between the payers and the providers for this type of work, we simplified the contracting model and it enabled us to grow and build a broad network very quickly. So we would have every year one contract upstream with Medicare, one with Medicaid, and then one with each commercial insurer that wanted to do business with us. And then we would singularly contract downstream with the provider organizations. And it made it much easier for especially small or rural provider organizations just to sign up once with us, and we would kind of manage the details with the payers on their behalf. A huge administrative burden relief for small organizations who just don't have the time, expertise, perhaps capability to engage in negotiations with each payer. So I think this is a really important concept. And I like this visual to show how it can really be streamlined and much more efficient if there's an entity like this in the middle. Next slide, please. So challenges, first, is it takes significant administrative effort to do this work, and the work shouldn't fall to the small practices, organizations delivering the care. So that was really the idea behind OneCare Vermont, is it's an administrative entity would take the burden of those contract negotiations and all the details within so that the provider organizations didn't have to manage that themselves. There needs to be a broad willingness to commit, invest, innovate, and collaborate. This is hard. First, you got to fund this work, because as I said before, it takes a lot of effort. It doesn't happen for free. So there needs to be a funding model and a commitment to support the organization. I think it's really important that insurers, that's all of them, Medicare, Medicaid, and commercials, flex and customize in spirit of alignment. This can be really hard, but when a payer has a very rigid idea of what they want to do and it's different than what another wants to do, that's a barrier or a problem. Buy-in from all sectors, that includes payers, providers, regulatory entities, state government, is really important so that everybody's working towards the same goals. And I think to get to this space, it might require a push from state or federal policymakers to just kind of nudge everybody there. I mean, these aren't really novel ideas in a lot of ways, but sometimes a little push is really important to get everybody on board, put aside their own personal priorities a little bit, and focus on the greater good. Next challenge is consistency and stability over time. We found it's really important. If you're constantly changing, it's a distraction and hinders progress. And I think that was actually a value of having OneCare as a centralized entity, is that we could push back a little bit on the payers from constant change and say, no, we actually want to stay the course and continue focusing on high priority areas in Vermont, one being hypertension, for example. That was something that we really wanted to stick with over time and ensure that that was in the suite of quality measures that we passed down to the providers rather than changing them every year or two. All right, next I'm going to hand it over to Dr. Wolfman.
Thank you. I changed my name recently, so you can call me Dr. Wolfman or Dr. Weigand. I'll answer to both. Thank you, Tom. So we certainly don't have all the answers. And again, some of this will sound like a repeat, but we want to share some more of our experience and observations with you. First of all, gaining alignment is a big lift. It isn't easy, as everyone else has already said. We made progress in this regard. We convened some multi-statewide conversations on controlling hypertension, for example, and social needs assessment, and those were very successful. But in my opinion, we didn't really reach our ideal state. I wish we could keep going and working with this model, because we did make some progress on alignment for sure. But it takes building trust and building relationships, and that takes time. We cannot underestimate the factor that motivations to do this work differ. So they differ from the payers, who focus a lot on money, the government, who focuses also on money and hopefully quality, very important to them too, but also on policy and who's in charge. And sometimes that gets in the way, in my opinion. Patients also, somebody else mentioned this already. Patients need to understand this. They need to understand that we are trying to make the system more affordable for them and more accessible for them. And I think we have a ways to go on educating the patients about what healthcare reform is and how it can benefit them. And then let's not forget the clinical care staff, all levels. They also really, in my opinion, didn't come to a full understanding about this work during the last 7 years. They are focusing on providing the best care possible while trying to maintain their work-life balance, not become burnt out, and then also they want to receive a livable and fair income. So those are some of the factors behind what motivates people in the different sectors. Building trust and relationships, again, takes time, and I think we have to be consistent. We found that the consistency is a little difficult to achieve when roles change frequently. Programs change, priorities change, there's policy turnover. So like others have said, consistency, shared priorities, coming together and collaborating on a regular basis, those are required. Attribution was a difficult factor for all parties, in my experience. So patients, clinicians, administrators, EHRs, it was kind of confusing to know who was attributed and who wasn't. And then how to look that up was also cumbersome. So I recommend that aligned models minimize this confusion, clarify the attribution, make everybody attributed. Somebody else already said this too. Busy clinicians don't want to look up whether somebody is attributed or not, or what their insurance is. We need that to just be in the background. And so we worked on this and we achieved it, but it was a little clunky, and I think it could be smoother. How does a multi-payer plan share data and analytics, and who pays for it? That's another big question. I think we made progress on that. I know most states have a highly functioning HIE. I personally feel like ours has made progress and could be even better. Sharing data sometimes feels conflicting. I think clinicians in particular are very protective sometimes of their own data, their own patient data. And so again, that takes building trust and understanding the reason behind why we need to share the data. The data has to be secure, obviously. That's expensive. Who owns the data? Who governs the data? And again, who pays for all of that? Technology is very expensive. And besides labor, I think that was our most expensive component in running the ACO. So I'd like to speak a little bit about oversight of the ACO, or lack thereof. I think that also really matters. And I'm happy to say we had a very supportive board of managers throughout. As far as what I could see, I think our leadership was excellent. Parent companies need to believe in and support this work. And I think we were also fortunate in that UVM Health Network and Dartmouth, who were our two parent companies in the beginning, were extremely supportive and eager to work with us on this project. In Vermont, we have a unique entity that Ena already spoke about. In fact, she worked with the Green Mountain Care Board in the past, and that's a unique case for us. They oversaw our budget, and they also required a very detailed annual certification process, which I think is pretty normal for ACOs. And we spent a ton of time on that every year. And I think it's fair to say that we would have appreciated more positive support from our oversight governing entity. All of these leadership entities should ideally believe in the structure, understand the requirements of the operation, be willing to back it financially because it is expensive. You cannot get experts in the field or the technology you need, on a little bit of money. It's expensive. And I think it would be ideal if people working in leadership to oversee ACOs and models like this had some kind of background in the healthcare delivery setting. I find that firsthand healthcare work experience can bring valuable insights. So I would love to see more experienced clinicians participating in healthcare reform. I think if you're explaining, you're losing. And if you're explaining, you're certainly wasting time. So it would be great if, we had even more healthcare experts who wanted to work on the healthcare reform. I think we're ready for the next slide. So during our tenure, we did witness benefits and value, and I don't want to underplay that. We gained alignment, we gained efficiency, and we were able to innovate. So over time, the providers did collaborate more and more. We had the visiting nurse associations, mental health associations, area agency on aging, primary care, whether that be hospital-owned, independent, or FQHCs, all collaborating. And in some of these multi-state collaborations, we had the Department of Health, we had Medicaid leadership, all at the table talking about how to work on hypertension control, for example. And so that was wonderful. That was unique and probably, in my experience, the most pleasurable part of this work. We did get payer buy-in, but you heard already that varied, especially in the commercial space. But I want to say that Vermont Medicaid was a part for the entire 7 years of the all-payer model, and we really enjoyed working with those people. Patient confidence struggled, I think. More education is needed for the patient population at large on what we're doing, and we need simple ways to explain the benefits to them. We did have a patient and family advisory committee, and so we got some input from our patients and families, but I think we just barely scratched the surface as far as educating the patient population. In quality, also mentioned earlier, we were able to gain alignment across the payers in the list of quality metrics that we wanted to work on. And I think because of that, we made progress. So some of the areas we especially made progress in are chronic disease conditions such as diabetes control and hypertension control, as well as preventive visits across the board, all ages. We improved in all those areas over time. In the area of efficiency, we made some progress in shared data and analytics. Again, more progress could be made, but we were able to move the ball. And our quality effort consolidation, I already mentioned, and Tom talked about our unified payment streams. I think he did a good job. I love the slide showing how we diminished the number of contracts required. In the area of innovation, we were able to, as we gained alignment and efficiency in the areas listed above, we had more time and energy to work on innovations and try new things. And you heard about our waivers earlier. I'll mention an example, the skilled three-day skilled nursing facility waiver that allowed us to admit patients to rehab without a 3-day hospital stay was an amazing focus of ours. And since the end of the pandemic, more than 300 patients got admitted to rehab without a 3-day stay. And that saved, we calculated, at least $2 million. So that and many other waiver projects were exciting. And we also were able, over time, to really hone our population health model into a streamlined model. So we integrated our care coordination requirements, mental health care screening, and provision of care, and social needs assessment as requirements into our quality program. And so our members had to be focused on those areas in order to have access to any of the incentive funding through our population health model. So those are just a couple of examples of the innovations that we started and we got involved in closer to the end of our model because we had freed up some time and energy so we could work on those. Much more we could say, but I think our time is up, and I'll turn it back to you, Lauren.
Thank you so much, Carrie and Tom. Really, really valuable information. And also personally really interesting. I'm sure we all crossed paths at the beginning of the SIM model. So it's really exciting to see all the development. So now we're going to open the discussion to committee members to ask questions for the next 20 minutes. And in the interest of ensuring balance for our experts, we just want to encourage you to keep your comments to a few minutes so we can get to as many questions as possible. So I want to open it up to committee members. Encourage you to raise your hand if you have a question. I have many, so if you don't jump in right away. Oh, Krishna, please go ahead.
This is fantastic. No, thank you for hearing your comments and the presentation. Really fantastic perspectives there. So appreciate it. I think that one thing that stood out was sort of we are moving at the speed of trust to some extent, right? Like the alignment always has like the human and trust elements within all the stakeholders there. Any sort of like guidance or recommendations on how do we speed up that alignment and trust? And I'd love some perspectives on that. I know it's like a hard question and this is such a human behavior thing, but curious to see if there's if you could do this again, like what would you do to make it faster? I'd love any perspectives on that.
Please go ahead.
Yeah, great question. I can add a few thoughts. So first is, at least in our experience, having the Vermont all-payer ACO model program come to life was that policy push that I think helped tip those who were kind of on the fence, say, all right, we'll jump in. And when we were growing our network, I remember talking to hospitals or primary care practices, and they'd finally say, okay, we'll jump in, but don't tell us what to do, kind of thing. But over time, the trust built up once they understood our intentions. But I do think that policy level push to get those who are on the fence who might otherwise kind of sit back and wait to see what happens to others was really helpful for us to grow and get more participants in our network.
Ena, please go ahead.
Thank you. I was just kind of looking back on how long ago we started on this work, which really was around 2013, where we said in Vermont, we want all payers at the table for payment reform. And we want to understand which payment reform models are going to provide the most bang for the buck and move towards the accountable care organization model because of its inclusiveness across the continuum of providers. I think that we struggled with trust building in some ways, and also we benefited in other ways. The state political climate when we were getting going had just been really focused on a single payer system for the state of Vermont. And I think in the wake of that single payer effort, there was a lot of excitement and willingness for providers and payers to come to the table together to do something other than single payer that could provide some savings and improve quality and access for the people of the state. So I think that there's also that overlay of the political climate that is very important in terms of what kind of trust and how you accelerate that trust building. And I'll emphasize again that meeting regularly with the stakeholders is incredibly important. We had a series of meetings in Vermont that were called the Monday morning meetings. And it meant that every Monday morning, the payers, the providers, state officials, and community agencies were all together around a table working on those standards for the accountable care organization. And that it had to be very consistent. It had to be a very regular interval of time, 1 week in between, and progress had to be shown between all of those meetings. And when there was less of that intensity, I think that that's when we started to see more drift.
So value to hear the specificity. I'm gonna, Katie, you had your hand up, and then Joseph, and then we'll go to another question.
And so this is just a real quick add-on to what the other two just said is transparency. Consistent transparency, even when there are challenges, even if there's a challenge to what you're trying to do, being consistently transparent to the extent possible really helps to continue to build trust and relationships, so that people don't think you're doing something in the background or not really bringing everyone along. Thank you.
Yeah, Katie nailed one of my 5 that I was going to share. The 5 that I would share would be regular formal and informal discussions. It goes back to the idea of being transparent across all settings, across all conversations, but you sometimes you want to share concerns and process them if privately, if they're going to derail the group discussion. So formal and informal touches, being data driven is huge, 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 huge. Focus on being driven by the data. And I've already quoted the book, Crucial Conversations. I'll quote Getting to Yes by Uri and Fisher, reinforcing conversations that are based on shared interests and not individual position.
Valuable advice. Let's go to Larry.
Great session. I'm always learning in every one of these sessions. Multiple members talked about data, and Joseph, you just mentioned data in your answer. There's a new term out today, and it's called SaaSpocalypse. AI has created a situation, we are in the apocalypse of SaaS providers. You have to own the data, you have to control it. The data has to be, data by consent. That's the most valuable data. So in your models, who owns the data?
Well, so Larry, I think that's I'll just take a quick one. And I'm sorry I didn't put my hand up, Tom, so I jumped ahead of you. But I think that's really part of where the governance structure comes in, because there's certainly state-based all-payer claims databases or HIE that can get funded through and the cost absorbed through the state or some kind of broader mechanism, broader state mechanism. But the data is so important, and it's so important to share the data. So I am with you in terms of how do we make sure we understand who can share, who owns it. In Maryland, it was really important to have a state infrastructure and having a state healthcare good that could build a data infrastructure so that providers could share, especially providers that cannot build their own. So if they can't put together their own HIE or their own Epic, other, the providers that don't have the kind of means and resources to have a sophisticated data system, important for the state to be able to support that.
Super important comment, Tom. And then when you're done, if you could pass it to Ena for comment.
Sure. I like that term, SaaSpocalypse. I have to remember that one, but yeah, it's a great question. I think my answer is going to come from the ACO perspective, but when you sign an ACO contract, they basically fill your life raft with a bunch of data and push you out to sea and say, good luck. So it's the most important tool you're given, and how to use it well and how to leverage it well is a critical problem to address. For us in Vermont, we kind of became the de facto data entity because we had these contracts with all the different payers, and we aggregated them into a system, which was a SaaS system. And the data governance work is incredibly complicated and important, but also ensuring the right access is available to participants in the network is really hard and often layered and cumbersome, establishing who has that care relationship when multiple providers out there clearly do. So I think it really should go beyond an ACO. I can argue that it would be much better to have a really strong state level HIE rather than ACOs that can make these data available to participants in a governed way, in a really thoughtful way. Because when it's done through an ACO, it's just the attributed lives, it's just for the payers that are contracted. So what we did, I think, was effective for our use case, but it could be done better at the state level, in my view.
Go ahead, Ena.
Thanks. I think what Tom just said is really interesting in terms of the ACO kind of becoming the collection point for the data, and absolutely it required it to do its work, but it wasn't when we were talking about having a statewide all-payer model that was really focused on the total cost of care for the population, whether they were attributed or not attributed to the ACO. Having a broader source of data was very important for that reason. And as Vermont now transitions from the all-payer ACO model to AHEAD, and thinking about the Medicare data that's so critical to potentially working in the AHEAD model, there's a real difference in where the Medicare data may come. The claims-based data may come to the state of Vermont rather than to the ACO. And for the state of Vermont to then have to integrate with other data types is the question, and how they pursue that work.
Thank you. Lee, please go ahead.
Sure. Ena, something you said kind of perked my ears up. We've been talking about the importance of transparency and shared interests, and I mean that's all about how you get people to the table. And I would love to have that conversation for another hour from your experience, just based in a state where major payers and or providers aren't even willing to even say what their interests are, because that's competitive advantage, and they're not going to go there, right? But assume you get them to the table. And you made the comment about it was hard to keep everyone at the table, and maybe towards the end there was less at the table than when you started. So I would just love reflections on, with that experience behind you, what types of strategies and discussions would you use to try to keep full involvement at the table throughout the full process?
Well, I do think learning from the intensity that we had at the outset of, again, very regular meeting cadence, the state being a supervising entity in the room for that. And then, I think that was all pre-implementation, that regularity of meeting and intensity of cadence with the state's involvement. And then I think that there was sort of a approach for implementation that was more like, oh, well, this is provider-led reform, and so maybe the state backs off on this kind of engagement and partnership ongoing on a day-to-day basis, and puts the model into the hands of the providers to implement. But I think what you heard from Tom and from Dr. Weigand as well is that, maybe more of a push would have been helpful over the course of the model, over the term of the engagement. And I think that may be a key learning, that the state's role really needs to be consistent, ongoing, and throughout.
Okay.
Would any of our other presenters like to comment on that question?
I would agree with that. And I felt that while I've been working at OneCare, it'd be really nice to have more support from the state, and not, shoving it down the provider's throats, so to speak, but, being a cheerleader. You can do this, let's work together, being a really positive force, but also requiring those ongoing weekly meetings, requiring alignment, requiring the payers to stay in, I think would have contributed to more success.
I'm going to add a follow-on question to that. So I'm going to quote your line, Joseph, that what we're trying to move people to is from transactional to partnership models. And you've all referenced some type of convening infrastructure, some kind of regular integration, some kind of regular communication, ongoing relationship building, and competency building. And I'd like to ask each of you what you've learned about what types of investments are needed to continue that sort of regionalization, convening, ongoing integrator role, really, infrastructure, including do you see things such as Medicaid waiver programs or others supportive to that kind of infrastructure? I'll open that up to all the experts. How would you finance that work going forward?
Happy to jump in. I actually have one other thought about the previous questions to go back really quickly, but one of the lessons in Vermont was that the Vermont all-payer model is a test of scale, and that was set up based on attribution, number of attributed lives. And you all probably know attribution has a purpose, but it's highly flawed. There are people that fall through the cracks all the time. I actually think it should have been based on the provider participants. So if I was setting up a new state level initiative, I wouldn't use attribution as the basis, really. I'd try to get a critical mass of providers to be in this. And had the model been set up that way, I think it would have been viewed much more successfully in Vermont. On the finance front, let's jumping as I'm going. The money talks, whether we like it or not. So in our model, we often, I believe this is the right thing to do anyway, but we would give out some sort of a base PMPM, particularly to primary care, and then we'd have PMPM opportunities that they could earn based on outcomes and results. And we changed the blend over time, started off with more free money, if you will, and then moved it back over time. And that worked pretty well for us, but it is a heavy cost burden. And we're funded by hospitals in Vermont. And as the hospital financial situation got worse and worse over time, due in large part to a lot of regulatory action, it just became harder and harder for them to come up with the investments. So, one of the many reasons I think we're shutting down operations, but I think some sort of investment is really important. It's just hard to sustain.
Super helpful. We're going to go Joe, Ena, Kay. We've got about 4 minutes, but want to really hear from each of you, your response. Joe, please go ahead.
Yeah, I think declaring long-term commitment to process change and outcome change, regardless of the framework of the change. I mean, look at Maryland, right? We started with a Social Security Act exemption, and then we went to a relatively simple contract. Then we went to a much more complicated all-payer contract, and now we're going to a HED, right? But we're still that's just that part of it, not counting the Social Security Administration, statutory, decades of change, just the contractual evolution part of it. We're talking about, the last 15 or 16 years, right? So the framework changed, but the idea that we're committed to this process, that hasn't changed. And money is always a big thing. I would be remiss if I didn't talk about a couple more barriers though, right? So in nursing homes, one of the barriers is the regulatory mismatch, right? So for instance, in Maryland, we have a behavioral health crisis, and we have some folks, not all, but some folks that would be are in long acute hospital stays with a primary clinical diagnosis that have, in addition to the clinical diagnosis, a behavioral issue, a behavioral diagnosis. And we're set up to help those folks. But that is a regulatory risk for the skilled nursing and rehab environment. So you have to be willing to take that risk. We have folks that clinically, for what they were in for their acute episode, let's say they were in for a broken hip, but they were fighting cancer. And so we are set up for their rehab part of their care, but we're not paid for their cancer drug, not appropriate in our setting, right? So again, there's a barrier for us helping that person. So going forward, identifying those barriers and figuring what the fixes of those barriers. Another one is, for instance, by the way, within our scope of care, we can do transfusions, but there's no rate for it. So, nursing homes are either eating that, doing the right thing, and paying for the transfusion out of pocket in our setting, or wrongly sending the patient back to the hospital for the transfusion where it's paid for. It's within our scope of care, but there's no rate for it, right? So sorry to unload that at the end, but more work to be done by all of us.
It's an important point. You can go briefly to Ena, and then we're at time. Ena, if you'd like to comment. Is that okay, Katie?
Sure, Lauren, I keyed in on your question about funding, and I think relative to the conversation we were having about data in particular, that there is opportunity for states to consider Medicaid funding, implementation, advanced planning documentation that supports integrated data models and that promotes interoperability of data. These pieces, particularly if Medicaid is a participant in the all-payer model that the state is pursuing, I think is a really significant opportunity for the states to draw down that 90-10 match and support better data.
Thank you all so much. All excellent presentations. I know we could keep talking to you for another hour, but we're actually at the break. So I want to thank you so much for joining us, and please encourage you if you'd like to stay on for our next session. It will be also going another level on state value-based care models. At this time, we're going to take a 10-minute break, and we'll be returning at 2:50 Eastern. So please join us then, and we have another great lineup focused on lessons learned from state value-based care models that have implemented multi-payer alignment. Thank you for joining us.
Produced by the U.S. Department of Health and Human Services.